Thank you very much. I've got about noon. We've got until 12:20 to discuss this topic. We had just now 3 really excellent speakers. I had the chance to see the decks in advance, and I had some idea how good this was going to be. I'd like to kick off with one question for any of the 3 of you. It seems like with the move to electronic health records, it'd be fairly easy to track, what's been done and what's not been done, at least with lab tests. So, but it wouldn't necessarily address the way we're defining underserved. So that lab record or that EHR record may well have a self-reported race in it for most people, but it may not have, did you finish high school or not, or is English your first language or not? It might not be in there. Do any of you work in health systems where there would be a priority or an interest to track access like this, like through the EHR alone, and maybe identify the people that are most missing things? I'll give you one example. I know people have tried with pharmacogenetics to look at pharmacy records and say, look, here are people that are on 9 different drugs, 6 of which have a heavy pharmacogenetic component. So that's the 4% of patients where we might try and do pharmacogenetic testing. Not everybody, but we could pull it out of things in the record.
So I can jump in. Yeah, you might have heard that the VA is actively deploying Cerner. We anticipate it'll be kicked off in about 2 years. We've had one of the first electronic health records in the United States. It was based upon a framework called Vista. Then we rolled out a front end for that. It was a GUI front end. And it is somewhat integrated across the country. And we have the data rolled up so that we can get national data. And we do predictive modeling in real time for a lot of things, for example, for suicidality. But it's still it's a little bit of a hodgepodge. I would point out that while we have genetic records, I think the CSER consortium published data. Genetic tests are poorly handled by the genetic record, and there was a previous genetic roundtable work group focused on that, the digitized consortium. And then family history is even though in some medical record systems it's standardized, there isn't that either. So I agree. Getting the data structured in a medical record is a separate issue, but getting a large platform and getting all of the data so that we can see each other's data. And even in the VA, a large percentage of the people use outside. About 50% of our veterans get some care outside and some inside. And exchanging those records is incredibly difficult. And I think most people change health systems when they change jobs. And you lose any benefit of an electronic record. And so working towards, I mean, it's great to say, oh, HL7, but it's a lot harder than that. So I look forward to the day when we can realize your goal there. Yeah.
And I would just add that I think that there's a lot of benefit to having an electronic health record in terms of creating searchable information and patients who might potentially benefit from things particularly like genomic testing. And just a brief example, when we sit down and collect a lot of information about a child, we do that at the OB visit, and we have all of the information, not only about the mom and her history, but also about the father's history, and we take that information and import it into the baby's record when the baby's born. So that's just an example of an elegant way to preserve information, and we have the ability to track all these people by diagnosis and family history and sort of generate these reports. But whether you actually do that at every visit, there's tons and tons of missed opportunities to collect information, or we collect information and it's not propagated throughout the record. We ask every woman about family history when she gets a mammogram, but not in a place that appears in anywhere else in the record. There's just so many missed opportunities because it's a paper record. We sort of have to enter the 21st century and preserve all that information we're collecting and communicate it across specialties and wherever the patient
and
goes.
She probably doesn't want to give her family history every 2 years at a different mammogram center either. For her part. We've got about 15, 20 minutes left. We've got probably 10 people lined up for questions. So let's start with a question in green.
Hi, thank you very much. My name is Meyer. I'm from Columbia University. I have a question that kind of comes across, I think, for all three panelists, but perhaps primarily for the last speaker. And that is the question, to what extent any of your work has been in connection with the population of people with disabilities. And I'm saying that, one, because this is the largest health disparity group in the United States, with 22% of the adult population only experiencing some sort of impairment throughout their lifetime, but also because we know that there is a significant issue of access to services across all types of medical treatment, including screening for cancers in particular. Although this population might have, some subgroups of this population might have increased risk for different types of cancers. And I know that women with disabilities are far less likely to be screened to any type of cancer, including mammography and all of the breast cancer screenings, simply because usually they're perceived just for their impairment and checked just for their impairments, rather than thinking about their health in a more broader and comprehensive way. And so I'm wondering, one, if any one of you recorded any data about impairments or prevalence of impairments within the population that you've studied. Secondly, how can we move forward with that population? Again, perhaps some of your studies suggested some of the barriers. I know that people with disabilities might have also unique barriers, such as access to clinics, access to information that is accessible for them. Deaf women have particular challenges in this context. And of course, how can we move forward with ensuring that this population is included in all of these conversations? Thank you.
So the VA does have a very high percentage of patients with disabilities. A lot of those occur during the service, and then of course they can occur after the service. Onset of multiple sclerosis, strokes. I need to speak up. Okay, and so I think we address that, and certainly the vision impaired and hearing impaired are a big segment. So we're a little different. We're highly tuned into that as a group of providers, and we do keep very good records of that. And I won't say we're a model for the ways of distributing care, but we can certainly, there's probably lessons learned from us. But our disabilities, again, are a little different in some senses than the broad American population.
That's an excellent point, and I'm a little ashamed to say that's really not something that sorry. That's really not something that we had focused on, but you're absolutely right, and that's something we need to start paying more attention to.
All right, question on the other side.
Thank you. Hi, Carol Weil with the National Cancer Institute. And I wanted to ask you about both the feasibility and the value of potentially leveraging direct-to-consumer testing into the efforts to increase equitable access. I think someone mentioned the point that patients do show up with their 23andMe test sometimes in the doctor's office, and the truth is I can spit in a cup and send it off for $200, maybe $100 if I'm getting a sale at the end of the year, and insurance is a lot more and often isn't available for so many people. So I wonder what your thoughts are on that.
I guess my comment is that I might encourage people to take a slightly different tack. I think the social media route brings up some really interesting possibilities. So there are organizations like Bright Pink, for example, who now have these social media platforms for doing risk assessments. I think they've had 500,000 women have done breast cancer risk assessments. And so that may be another strategy to try to make it a little more, democratically available. And then that's getting people into the counseling and the education they need sort of on the front end. So that, I guess I'd be a little more interested in seeing it go that direction.
I sort of have mixed feelings. I think it can be a tool used in education, but by and large in clinical genetics, we don't use polymorphism testing routinely for most kinds of things. It does have uses, but it's not the first line for a lot of things. And so in the same sense that somebody's getting a clear mammography report and so they says, so we have no genetic risk. When one gets a 23andMe report, they think they have no risk for cancer or breast cancer, even when only a very small subset of potentially pathogenic mutations was tested. And so it probably has a place, but I'm not, we get self-referrals based upon that. And then what it turns out is the people that have gone to use it were the people at high risk. And we should have had a family history taken and the appropriate panel tested.
There's something that's sort of in between with DTC, but it involves that DTC approach. Medicare for decades has covered fecal testing for colon screening. And then a couple of years ago, they covered a new DNA-based fecal test for colon screening, somewhat more sensitive and specific. But the first test was $10. The new test is $500. So one of the things that happens, you get the DTC angle. They can have advertising. They can call people at home. They can have direct mail. They can detail physicians, which the $10 test couldn't do. Now, you can ask whether it's an unintended benefit or not, but it's you start to see this thing in a public health issue because the test is so much more expensive. This side.
Yeah, thank you. My name is Li Yang. I am a PhD in economics by training, but I'm more interested in a variety of social issues. So I appreciate this panel and previous panel. We are focusing on health, but I don't know if you verify the data. The data is very important, and whether you are investigate the misconduct of our health providers, or whether there is a physician, or whether there's a VA hospital or rehab centers, or whether their family has been broken down, not because they don't have a capability to have very good families, and whether they have been relocated because of health health facilities. For instance, if you live in Montgomery County, Maryland, but they can transfer the patient to a different county, and with all different kind of diagnosis and misconduct. And so I have seen the VA patients, they have been transferred from one health center to another, one rehab to another. So eventually VA, not only they don't have a problem of health, but they are deprived of all their VA benefit. What I mean is they rob government resources to benefit a few, to benefit the providers or psychiatrists or social service workers. And then they also deprive or rob their family income. Suppose if you have a health, no, what I mean is if you have a good income within your family or your grandparents want to have asset to the grandchildren for college education, they will be all deprived of. And then they will have a diagnosis, a false diagnosis, and unjust injection, everything possible. So I just want to, unless we fix this, we investigate this, all of health facilities will be very much misleading and mislabel everything in terms of health, but actually it can be a murder and can be everything possible. So it's very important. I just want to, especially now, this is not just for health or family reason, but also for political reason. If you're an opponent, you are in trouble. And this especially now, PPP program, this propaganda almost everywhere, every corner, every government agency. Now they even have
Thank you. I think we've got the question. I think the issue of accuracy and false positives in genetics, probably with the VA system and Colorado and University of Illinois are using CLIA labs and low chance of false diagnoses. Question on this side?
Thank you. Sue Friedman from Force. And I had two questions for Dr. Hoskins. One, for your new paradigm, have you thought of partnering with an advocacy group? And I was glad that you mentioned, for example, Bright Pink in their screening. We have a peer navigation program at Force where we match people with the idea of trying to overcome barriers. So these are people that have been trained. They've been through a training program, not to give medical advice, but they are matched by circumstances and geographically with someone as similar to them as possible. And so, we feel that might help overcome some of the patient-based barriers such as fear. And, to talk to someone who's been through it, who has had genetic counseling, can tell them. So I think it's helpful that they get a description of what genetic counseling is, but also to speak to someone who's been through the process. And then I had one more question, and that is, I noticed that you called it the breast cancer risk screening tool, and I was just wondering if you thought that maybe it perpetuates that same idea that this is like that BRCA testing may be for breast cancer only, and do you have any thoughts on changing that? Thank you.
Second question. First, we've retired that tool, so that's an old tool, so we don't use it anymore. but you're actually very good point. To your first question, I think that's a great idea. So what we've been doing is we have been working with a local advocacy group in Chicago. We haven't kind of thought big yet, but I think those are excellent ideas, and I think you're exactly right. And if we think about mammography, for example, we know that navigation is probably the single most effective way to get underserved women into mammography. So that model, I think, has been tested and proven, so it would make good sense to use it in this situation as well. I think that's a great idea.
Thank you.
Rena Pasick, University of California, San Francisco. Dr. Hoskins, if this was a small meeting, I would just take you aside afterward. But because of the exposure that this is getting, I'm compelled to come to the microphone to question some of your methods and basic premises. I'm going to be reporting after lunch on several of our studies where we anguish over the fact that only 50% of our low-income, ethnically diverse, high-risk women are coming to counseling. I think that the previous questioner raised some really important points, but missing in your approach was attention to culture and sociocultural context, and I particularly question for the researchers who are interested in this, the focus on the construct of intention, which in 2009, my colleagues and I did a 7-year NCI-funded study to explore the cultural appropriateness of constructs like that, found them to really have a huge disconnect in culturally diverse populations. So I had to raise that and suggest that you were going along the right road in terms of the more qualitative approaches that you looked at, you used to try to understand your results. But I urge you to look at the literature on culture and health behavior. And there's quite a bit written now, but I want to discourage people from using the old theories from health psychology that really are a disconnect with the populations we're concerned about.
I'd love to hear more of your thoughts on that. And obviously I gave a very quick overview, so I completely agree with you. And so, we're very much working on culturally appropriate tools and methods. I didn't have time to get into those details, but I would love to hear your advice on better models. I'm not a health psychologist, I'm an oncologist, so I rely on my colleagues in health psychology who kind of suggested that model, but I'm sure there may be better ones.
Kathy Wickland, NSGC in Northwestern. And I want to thank all of you guys for great presentations. And I have a question about the actual tiering or triaging of, who gets genetic counseling versus not. And I hear a lot of discussion about complexity of indication or complexity of the results or positive versus negative and who might need genetic counseling based on that. What I don't hear as much about is actually the psychosocial components and thinking about the complexity of the patient themselves, of that person, level of anxiety, different things that they might perceive their risk to be or not to be based on their results, the impact of a positive versus a negative. And a lot of times we discount negatives because they're less complex because of maybe they don't require some of the same kind of follow-up. But I wonder how we can do a better job at thinking about triaging beyond just the complexity of the actual indication or genetic test results and think broadly about the psychosocial component as well. I wondered what you guys had thought about or if you'd thought about that in your discussions.
I've thought about this because I think a lot about when we send people for testing, sometimes there's a clear pattern in their family and there's something that can affect them and their risk doesn't necessarily go down if they have a relative who has some condition and we just haven't identified it yet. So in some ways it can actually cause more anxiety for the patients. And I think a lot of people here have alluded to this really important component of peers and communities and family, that this is really a family disease. And having someone there who's been through it, having support groups or advisors that are on site is really important. And so we have to identify that it's not just getting people into testing and tracking them, but providing them support down the road, regardless of their result, because there's a ton of anxiety around this. Right. You know, there's a ton of anxiety around any kind of cancer screening, particularly breast cancer. Right. So these patient supports and helping people downstream really is important. Yeah. Thanks.
Yeah, I strongly agree, and I really think that, you know, our service does a lot more than just provide genetic testing.
Right.
And in fact, we don't test in about half of the cases. And you know, there's still a process that goes on. And then with a negative test, it's an education of both the provider and the primary care team about the appropriate follow-up plan. Because, as Katie just said, the risk doesn't necessarily go down.
Right.
All right. Thanks to all the speakers this morning from the keynote on who have kept us right on time. It's 12:20 now, and we'll begin with the third panel on providers after lunch at 1:20. Thank you.